Hi everyone, so we can record. Are you hopefully okay with the recording? You will receive soon. Hi everyone, it is a pleasure to welcome you all to this webinar on the barriers to gender-based violence health service in humanitarian setting during the COVID-19 response. The report on and finding and lesson learned from Bangladesh, Bazar, Iraq, and Northeastern Nigeria. During this one-hour webinar, we will explore the impact of the COVID pandemic on gender-based violent health services in humanitarian setting. I'm Donatella Massai, Technical Advisor, COVID-19 Task Team, Global Health Cluster, and I will moderate this session. With us today, we have two presenters, Ms. Saba Zarif, Gender-Based Violence Advisor, from the Global Health Cluster that will make the opening remarks, and Dr. Krista Bywater, Senior Advisor Gender Equality at Save the Children, who will briefly introduce the finding and lesson learned of the report. And as I say, we also have three influential panelists from different countries to answer key questions. So with us today, we have Dr. Mahmoudul Alan, Sector Lead Health and Nutrition BRAC Humanitarian Crisis Management Program in Bangladesh, Dr. Hur Amer Salman, Head of Medical Committee, Dairy Humanitarian Organization in Iraq, and Dr. Midala Usman Balami, Sexual Reproductive Health and GBV Officer, UNFPA Nigeria. Before we start, let's provide some housekeeping information. This session, as we said, is recorded, and the link with the recording will be shared in the next few days with all of you. If you have questions, please post them in the chat box and we will answer them during the question and answer session. As mentioned already, this webinar is in 3 languages, English, French, and Arabic. Please choose the language that you prefer. Last but not least, I'm asking all speakers to be on video at least while they are presenting. I will now leave the floor to Ms. Saba Zarif, Gender-Based Violence Advisor of the Global Health Cluster, for the opening remarks. Welcome, Saba.
Thank you, Donatella. The COVID-19 task team was established by the Global Health Cluster in the early weeks of the pandemic response, with the purpose to support the promotion and development of knowledge and guidance to mitigate the health impact of COVID-19. We did this by looking first, by trying to identify operational challenges for health service providers across humanitarian settings. From the outset of the pandemic, the task team acknowledged a growing concern within the global humanitarian community regarding a dramatic increase in reported cases of gender-based violence. By April of 2021, we had already witnessed in countries around the world that there was this stark increase in the calls to dedicated sexual violence and intimate partner violence hotlines, ranging from 60 to 770%. Projections had indicated that for every 3 months of lockdown measures, an additional 15 million cases of GBV globally were to be expected. This called for the humanitarian community to rally in response. And as humanitarian actors adapted and innovated healthcare solutions to address the needs of GBV survivors, the COVID-19 task team and the READY initiative undertook the work of compiling learning from the field and really trying to create a document which would allow us to understand the barriers to the availability and accessibility of health services in the COVID-19 response and recommendations for how to maintain healthcare for survivors of GBV. With a tremendous thank you to the READY initiative and the COVID-19 task team partners, the findings from this report will be shared with you today, in addition to lessons learned from our panel of humanitarian professionals. The pandemic response offers us a strong reminder that gender-based violence is a major public health issue. Health services for GBV survivors must be recognized as services essential to the COVID-19 response effort as the pandemic response evolves over time. And our efforts have to continue to innovate and adapt care approaches to ensure the continuity of these services. Our hope is that with the discussion today, we're able to take a retrospective look at what's worked in the past, understand better what barriers persist and how we have to anticipate changes in the response effort to COVID-19 in order to make sure that the needs of gender-based violence survivors are prioritized within the health sector. Thank you.
Thank you, Saba. Thank you very much. We now have Dr. Krista Bywater, Senior Advisor Gender and Equality at Save the Children, who will briefly introduce the funding and lessons learned from the report.
Hello, everyone, and so good to be with you today. Thanks so much for the introduction, Donatella, and very briefly, I have 10 minutes to share with you some of the key findings from the report. So this report, just as some background, it looked at literature and evidence published between March 2020 and May 2021. Of course, so much has changed in our world since then, so the goal of my presentation today is really to provide some background, and then the panelists from each country are going to discuss the latest developments in each context. So at the very high level, we know that there are numerous ways that COVID-19 has impacted GBV health services, including some of the key areas here. So of course, we saw tremendous reallocation of resources whereby many governments and humanitarian actors prioritized pandemic response over GBV service provision, resulting in many programs and services operating at reduced hours or with skeletal staff. Looking at the second box here, we know that at its most extreme, some providers were forced to suspend activities altogether. And obviously, a lot of this was due to the severe lack of funding and resources. So just as a quick example, we know that as of 2020, the Global Humanitarian Response Plan only included $50 million for delivery of GVV programs. And that was only in 16 of the 63 countries that were entering or were in humanitarian emergencies due to COVID-19. And finally, in the last box, as you can see, we know that GBV case management, including reporting mechanisms and referral pathways, were disrupted, obviously limiting survivors' access to services, and in this context, a lot of organizations pivoted to virtual support, which we know is certainly beneficial in terms of being able to continue some services, but leaves many survivors, particularly women and girls, with limited technology access, with severely limited ability to access services. And finally here, also wanted to point out not just the issues or the ways that survivors themselves are impacted, but the impact to healthcare providers themselves. We know that there were a lot of mobility restrictions, which impacted their ability to get to facilities. Of course, they themselves had limited access to personal protective equipment and had to deal with severe concerns about contracting COVID-19 and in turn spreading that to their colleagues and families. There is, of course, a gendered dimension to this as well. Female healthcare workers make up 70% of the workforce, and they themselves face challenges such as GBV at home and en route to service delivery points. So as you can see on the slide, just very high level, want to overview some of the common barriers to GBV health services. We know, if you're looking at the left side of your screen here, that survivors, for them, lack of money and resources impacted their ability to access services themselves. Of course, the mobility restrictions and quarantine requirements that often came with COVID-19 measures imposed by governments further restricted access. Certainly transportation was disrupted, and there was, due to the isolation measures as well as lack of in-person interactions, certainly access to accurate information about GBV services, updated information was difficult to get. And on the provider side, some of these I've already mentioned, but just noting, we know that supply chains were disrupted. So access to supplies, especially for sexual and reproductive health, were difficult to get. A lot of the time, given the shift to remote service or the mixture of in-person and remote meant that providers were changing operations quickly and didn't always have adequate protocols to deal with the changes. And providers themselves really suffered from a lack of mental health and psychosocial support at facilities, which impacted their ability to provide services. Turning quickly to the context that we're going to focus on today with Cox's Bazar, we know that all those barriers that I've just previously mentioned, the common barriers, existed here, but just noting some particular ones. The first one certainly around misinformation that continues to be a problem everywhere. But in this case, we definitely saw early on misinformation about COVID-19 screenings being required to access GBV services. And we also saw rumors that survivors would need to be placed under quarantine if they accessed services. And obviously these served as a deterrent. There were many responses and adaptations by humanitarian actors. We saw volunteers being trained to fill service delivery gaps, a lot of frontline health workers receiving gender equality training to make sure that they had the latest information in order to adequately adapt to the surge of GBV cases. And we saw that providers continued to engage with community leaders in order to ensure that messaging was getting out and that referral pathways were updated. And there was a lot of on-the-ground work, including the health cluster translating the clinical management of rape and IPV guidelines into local languages to make sure that they were accessible to providers as well. Turning quickly to Iraq, I just want to highlight, in addition to all those common barriers, we saw that GBV service providers faced movement restrictions and in many cases needed to obtain government approval to continue to function. We also saw the suspension of lots of services like the family protection units, which are important avenues for survivors to gain access. And in response, the humanitarian community adapted in a variety of ways, just highlighting the first few bullets here. We saw that in collaboration with Iraq's health and protection clusters, providers channeled resources into things like trainings and training sessions on the GBV handbook, GBV related issues during COVID-19, and we're really trying to address social stigma that was associated with COVID-19. And as well, we saw, given just the lack of funding and for GBV specific programming, we saw the integration of GBV along with mental health and psychosocial support messages being incorporated into existing health activities and messaging. And the Dari NGO, for example, did a lot of this work, and we have a representative who will talk more about this today. And the final context that we'll look at is Northeastern Nigeria. We know in here that there were many of the same barriers, but specific ones to this context. We noticed that even when services were technically open, many staff struggled to get passes that would exempt them from movement restrictions and allow them to travel to service points. Often healthcare workers reported being reluctant or concerned about treating internally displaced persons out of fear of contracting IDP. So there were social and cultural barriers too. We know as well that many of the COVID-19 measures that were implemented early on restricted IDP's ability to leave camps and access services appropriately. And all over the world, but particularly in this context, we saw the increased presence of security agents and community militia members who frequently are known to harass particularly women and girls as they were traveling to providers. And of course, they can act as deterrent. And they did in this context. And certainly here, given the emphasis on security and the enforcement of COVID-19 measures, there were a lot of security present, but focused on enforcing those measures, and they weren't readily available often to take reports and offer referrals. So just to highlight quickly, the speakers today will talk about existing adaptations and ones that continue today, but I just wanted to highlight the EU-UN Spotlight Initiative that was launched to fill data gaps and identify trends particularly. And so we saw it built up the GBV data situation room and dashboard, and also a lot of toll-free hotlines that operated on 24/7 basis also came up as well to really deal with the increase in cases and reporting, particularly on the remote side. So finally, very quickly, I want to highlight some of the overarching recommendations that are noted in the report. Of course, we know that there is no single or easy solution or set of adaptations that will address the needs of all GBV survivors in all contexts. These are just offered here and in the report as starting points to adapt approaches and programming as appropriate for different contexts. And in the full desk review, there are also recommendations for different actors like UN agencies, donors, and governments. And then there are country-specific recommendations for each of those actors too. So one of the lessons learned definitely is that we know that we have to designate GBV services as essential to ensure adequate funding and the continuity of services and access for survivors. Also, there's an importance to continue sexual and reproductive health and mental health and psychosocial services, particularly when it comes to SRH services. We know that these need to be in line with the minimum initial package for SRH in crisis settings. And given the disruptions to commodity chains, we know that it's important to prioritize access to particular medications, including PEP and emergency contraception. If you look at point 3 here, there was a big emphasis in a lot of the evidence that we saw about the need for improved coordination among actors in order to integrate GBV prevention and response into COVID-19 plans and activities. This is especially critical to ensure the sharing of information and to avoid redundancies in activities themselves. Under 4 here, we know in the rapid response, there wasn't often an emphasis placed on conducting research. And so really emphasizing the need to conduct intersectional GBV risk and gender analyses and to use those findings to systematically incorporate GBV risk mitigation, prevention, and response strategies into COVID-19 measures. So again, the need for that research, even in humanitarian settings. And under point 5 here, again, finally, I want to emphasize really the need to amplify the role of gender experts, female healthcare workers, women leaders, and women-led organizations. We know that their participation is essential to ensure that responses use gender responsive strategies that adequately address the needs of women and girls in each community, and not to exacerbate GBV risks through COVID-19 programming. And lastly here, we know that GBV programming is going to continue to be underfunded. And so this last point here is really getting at the need to ensure that risk communication and community education on COVID-19 is accessible and incorporates information on GBV prevention. So as noted, there are many other recommendations and findings in the desk review. These are just some of the key highlights that I wanted to mention today. So thanks very much. And turn it over to the other panelists.
Sorry, I was muted. Thank you, Krista, for the report and especially for this last recommendation, very important. And now if you can stop sharing, I'm gonna share the question for our panelists. I hope. I'm not gonna, here we are. I was able to share, I'm happy. Can you see the question? So our first panelist is Dr. Mahbubul Alam, sector lead health and nutrition from BRAC in Bangladesh. And the question for him are twofold. The first one is, how did health services provider and facilities supported by BRAC adapt in order to ensure healthcare services for GBV survivors were maintained throughout the COVID-19 pandemic in Cox's Bazar, Bangladesh? Why was this approach used? And the other question is, are the recommendations of the desk review that we have just seen still current? Thank you, Dr. Mahbubul. And the floor is yours.
Yeah, thank you, Donatella, for the question. So from the desk review, it is evident that the first effect of COVID-19 was like movement restrictions implemented by all the government authorities in Bangladesh. So at the beginning, our health staffs also were facing the same restrictions. They were not allowed to enter into the camp by the security agencies. So later on, we communicated with the government agencies through ISCC Health Cluster to ensure access for the health service providers to the camp. So the service for the GBV survivors that can be continued from the health service centers. That is one. And also the service seekers also faced the same restriction. They were not able to go to the health centers due to restriction and other things. And misconception among the community people, that was very much high. And also in the service providers also. At the beginning, the service providers were very hesitant to provide their service in the health facilities. Then BRAC trained all the health facilities staff on COVID-19 to get them equipped with right information with COVID-19, and also equip them with preventive materials so they are confident to provide the services, to continue the services. And also our community health forces, they went door to door disseminating the messages of COVID-19 prevention and how it can be prevented. Those help the community people to avoid the misconception like if they are coming to a health facility, they will be affected by COVID-19. They will be kept quarantined if they are visiting health facilities. This helped the community people to come to health center to take the services. And supply and logistic was a very much challenge at the beginning of the COVID-19 as all the supply chains was disrupted. At the time, we communicated with the UN agencies here also. We supplies and logistics UN agencies here in Bangladesh, and also we channel and we could ensure the logistics and supplies for the staff and to run the health facilities. And this was ensured. And definitely the capacity of the service providers from the health facilities, that is very much needed. We ensured the training for the health service provider on managing GBV survivors cases. They were trained on clinical management of PrEP. They were trained on MA's gap, and we ensured all the logistics to manage the cases there. So they're confident enough to provide the services for the GBV survivors. And collaboration was a very huge effort here, because the protection services were not considered as essential services at the beginning by the authorities here. So we collaborated with protection sector and also MSPSS sector to disseminate the messages through a coordinated channel. Even the protection field level staff and volunteers, they were trained to disseminate COVID-19 messages, so that they are identified, they are working for prevention of COVID-19. Side by side, they also could work to identify the GBV survivor cases, and they can provide the necessary information to come to the health center. And in our health facility, we especially focused on integrating the services. Like out from our health facility, we have GBV service providers from one setup, and also we had MSPSS service providers in the same facility, like psychologists, psychiatrists. So if any GBV survivors case are coming to health facility for service, after clinical management, they were referred to MSPSS service providers for receiving the services, and also for legal and other services, they were referred to protection colleagues. So why was this approach used? Because for the restrictions, we were not able, the protection colleagues were not able to access to the health facilities and also the field. That's why the collaboration, the training, and also the advocacy with authorities to allow access to the protection colleagues and also health colleagues to the camp and also health facilities, so the services can be continued in an uninterrupted manner. And then the recommendations that came from the desk review, yeah, still those recommendations are very valid because due to COVID-19, the focus of the world is shifted to other areas. Like at the beginning, the focus we were focusing on establishing COVID-19 treatment and isolation and treatment center. A lot of funding were diverted, and protection activities were identified as non-essential services, and a lot of funding were diverted. So yes, and also another thing that we have to mainstream the protection services within the health sector. In Cox's Bazar, Bangladesh, there is a SOP developed by ISCG Health Cluster for mainstreaming gender GBV services in health facilities. We are also trying to comply with that SOP so that the services are mainstreamed within the health facilities. Thank you. This is from me.
Thank you so much, Dr. Mahbubul Alam, for sharing your vision with us, and especially from your country. It has really provided a great perspective of GBV during COVID-19. Thank you again. We now have Dr. Ur Salman, Head of Medical Committee, Dairy Humanitarian Organization in Iraq. I hope we can see on video. If you give me a sign, I will go with the question. The question for the second panelist. Okay, perfect. Yeah. Thank you. So I'm going to read the question, not for you, but especially for all participants. What are some of the lessons learned from the work of Dairy Humanitarian Organization on delivering of mental health services for GBV survival throughout the COVID response in Iraq? And what are the key considerations for health providers responding to the COVID humanitarian setting to ensure the health needs of survival are not overlooked? And finally, at this stage of the COVID-19 response, have needs changed to maintain high quality GBV health services where you work?
Yeah.
And the floor is yours. Thank you.
Thank you very much. Hello, everyone. I will make it brief to answer all of your questions regarding the settings of the COVID-19. Actually, we started to using the personal protective equipment for all beneficiaries and for all the staff working in this center, and we started with awareness session for the beneficiaries and the social distancing, also using the distancing between each beneficiary and survivors. Then the work starts more hard through the curfew and the complete lockdown, which is so hard to beneficiaries to attain to the centers to get the services. Then we started to work through phone calls. There is a hotline for the psychiatric to answer all the survivor needs, and he can determine if this case need to attain the center or not. But there was a challenge to reach the center. I mean the access challenges. So then we have to find way for transportation of those survivals to the center. So in this case, we need an agency or an national or international organization to maintain this process of transportation of the survivals and bring them to the center to get the services. Also, there was a field team for outreach. Those teams consist of psychiatric, psychologist, and nurse, female and male staff, to reach those survivals. Once we determined by ourselves or by other agencies to determine those need services. Also through coordination with local authorities, local partners, and other partners, and using referral pathway. Then we will work through appointment list. So in this case, we bring to the center only who need service at site. I mean, if somebody can get service through phone or through like online or through remotely, it's okay. But if they can reach the center, it's okay. They can get services through the list. Appointment list, very good things that determined each beneficiary or each survivor definite time to attend the center. So each survivor will not meet another survivor. So in this case, it minimize and decrease the social stigma of some survivors, that no one will see him at the center during getting the services. Also, prescribing medication for long time as possible, as the case is indicated. For example, we like the psychiatric or case manager for the GBV, they can prescribe in case of medication for 29 days at maximum due to governmental regulations. So in this case, to minimize the number of visits to the center, to reach the services, and will stay on follow-up. All these key information was followed by all the humanitarian partners to provide services during COVID-19 pandemic. Yeah.
Thank you, Dr. Salman, for your perspective on GBV in Iraq. If you have finished your presentation, I will then pass to our last panelist before we go on question and answer session. So our last panelist is Dr. Midala Usman Balami, Sexual Reproductive Health and GBV Office, UNFPA, Nigeria. Dr. Midala, the floor is yours. And the question is, the desk review looks specifically at barrier to healthcare for GBV survival in the first month of the pandemic response. Since then, global cooperation has led to development of vaccine and their rollout and the rise of new COVID-19 variant. Have these more recent development introduced new barrier to health service provision for GBV survivor? In Northeastern Nigeria, how has UNFPA adapted its GBV health services approach to address newly developed or persisting barriers? And the second question is, at this stage of the COVID-19 response, what is needed in terms of tool, resource, support, capacity to ensure quality GBV service are maintained? Dr. Midala, the floor is yours.
Thank you,
welcome.
Thank you, Donatella, for this opportunity. Good morning, good evening, good afternoon, colleagues, and thank you for having me. My name is Midala Usman Balami from UNFPA, Nigeria. Thank you, Christine, for highlighting some of the barriers during the DEX review. I want to acknowledge that the barriers reflect what really was during the COVID-19, but just to actually also give us a quick update on the context of the northeastern part of Nigeria, mainly the Bay State, that's the Borno, Adamawa, and Yobe. Just to also mention that as at the year 2020, the humanitarian crisis was in its 13th years, and the crisis have impacted so much on life of individuals, with about 1.8 million people that are internally displaced. And the humanitarian response plan of the 2021 have captured about 8.7 million people in need of humanitarian services, while the humanitarian community was targeting 6.4 million people. As well, the GBV subsector has also looked at it critically, and we are looking at about 3 million people that are in need of GBV services. To that, they targeted about 1.5 million people with GBV services. This includes healthcare services to survivors of gender-based violence. If you look at it with the years of the crisis have gone to a level of becoming protracted, and because of the situation of the crisis, IDP were overcrowded, staying in communal shelter, a lot of disruptions within the camps, and the northeastern part of Nigeria also is known to be endemic with diseases such as diarrhea, malaria, Lassa fever, and others. So the COVID-19 pandemic really become a threatening disease, and people are prompted to respond in a manner that can provide life-saving services to the affected population. So because of that, the GBV subsector, the platform, was very proactive. One of the first approach they took was to actually develop a response plan, and that response plan fall within the COVID-19 framework, and then the MISP, the Minimum Initial Service Package framework. Kudos also to the UN and the humanitarian platform. They were able also to classify GBV services as PC1, life-saving services. That was one of the advantage that was given for GBV services to be continuously being provided during the COVID-19. So in the northeast part of Nigeria, these were some of the earlier approach that was taken to, first of all, develop an SOP, develop a response plan, a policy that give opportunity for health workers to advocate for health workers to go and provide services despite the restrictions. Though there were so much of, just as highlighted earlier, rumors that within the IDPs and also the affected population, that the humanitarian community may spread the COVID-19, but those were one of the avenue that was taken advantage of by the GBV platform, where communication and information disseminations were developed, capacity of health workers and other non-GBV providers were developed, so that once they reach out for providing services and there is disclosure for GBV services, they will be able to provide services. And with this, services were sustained and also was enhanced. So not only for GBV services, but also essential sexual reproductive health services were being provided. And innovatively, we leveraged on some of the application of, one of it was a use of medicalized mini ambulances. So these mini ambulances were equipped with PPEs and infection prevention control. Health workers were trained, and it was also coordinated with toll-free lines where survivors and social workers can call on the providers of these mini ambulances to move to the location of where services is needed, and services are being provided within the quorum on the guidance of GBV principles, with confidentiality being also sustained. Across of it also, we have worked closely with partners, local organizations, develop a simple system known as Smart RR. The Smart RR was developed also as a part of a phone-based system whereby social workers and survivors can simply use their phone, Android phone or basic phone, to report or refer incidents of GBV services. And using that, it can call on the providers, mainly of the mobile team that we have across the locations. And just to also highlight that the mini ambulances were developed because of the terrain in the Northeast, where we have rural areas, we have scattered settlement, the mini ambulances can move to these locations, and maintenance of these mini ambulances were easy. And since they are well equipped with PPEs, provisions of life-saving services become also better. So with the more recent development, barriers that were also posed include other rumors that continue also to give more echo on the earlier rumors of Humanitarian having possibility of transmitting COVID-19. Those informations were overcome through sensitization and awareness. So the first thing was awareness and sensitization were put in a format where we are using radio stations, we are using television to share information about COVID-19 and how COVID-19 is being transmitted and how one can actually use non-pharmaceuticals, face masks, and also social distancing so that you can be away from, cannot contract COVID-19. So mainly also just to add that what is needed at this stage of the COVID-19 response include tools that need to be developed, include SOP for remote case management. And just to highlight also that these tools have also been developed, and GBV services have been designated as life-saving services, which means it's also part of the COVID-19 response plan. And then it gives opportunity for us to kind of put it in terms of a contingency plan to procure life-saving SRH kits, including post-exposure prophylaxis and emergency contraceptives, to be kept so that response can continue even during COVID-19 or any other emergency pandemic that may come in the future. We also have these toll-free lines that have been harmonized across the Northeast, Borno, Adama, and Yobe, just to centralize and ensure that toll-free lines and capacity of those to manage the toll-free line have also been developed. And we continue to also take advantage of using this mobile technology to ensure that services are not interrupted, and the mini ambulances are also utilized. And then frontliners from the different locations of the IDPs were trained to be able to refer cases safely within the interagency standing committee framework and guidelines without any problem. So these were some of the efforts that were done in the northeast part of Nigeria to ensure that GBV services, healthcare services are sustained through this period of COVID-19. So thank you very much for having me.
Dr. Usman, thank you very, very much for your presentation, and especially the insight in Nigeria and Northeast Nigeria. Really, thank you so much. Thanks to the three panelists and the two presenters. We are almost perfectly in time, I would say. We can start our question and answer session. I'm going to go to the first question, and then we see how we go. We hope to complete the list. Otherwise, we'll try to juggle a bit on the questions. The first question, and probably I will ask you, Dr. Usman, because you're working in a conflict context. The question is how to act in case of armed conflict contests combined with COVID-19. Are there any initiative to mitigate GBV in such a context? Probably this is what you have spoken until now, but I think maybe it's important to answer to this question.
Yeah, thank you very much for that also very critical questions. Just to elaborate a little bit, part of what was adopted in the Northeast is the use of the mobile team and streamlined with, but the mobile team also, we use the traditional birth attendants and community workers to be part of the training so that they can facilitate referrals. These include a quick capacity building for these frontliners to be able to link survivors with GBV services, most especially healthcare services to the survivors. So that was most adopted in the Northeast, and services were provided without interruptions. And despite some of the barriers, people were able to access services without problem. Thank you.
And thank you again. Our next question, and sorry, I didn't say the name of the person who asked the first question. I can go a bit back. It's Diana Mada. And now the following question is about mental health. So it's Nashaba Zafar, Senior Technical Advisor, GBV Chorus International USA. The question is that mental health services are important for men as well, and especially in the pandemic, as their mental health issue were one of the major causes of domestic violence during lockdown and due to losing job. Were there any effort to provide services to men? Maybe this question I would ask Dr. Salman to answer, because they are working on mental health, but any other panelists can or speaker can answer. Dr. Salman, do you feel like answering?
Yeah, okay. I will answer, no problem. Regarding the mental health services in Iraq during a pandemic, as I mentioned, in the case of a complete lockdown, the patients was not able to reach the center. What we did, we start to determine which case can be prescribed medication for 1 month to receive the medication, then they will stay on follow-up through phone calls, and the psychiatric will follow up them remotely until the next visit will come. So this minimizes the number of reaching the center during the pandemic. In the same case, who cannot reach the center due to lack of transportation. Also the session, I mean the recommendations, the awareness session for mental health to help was helping the beneficiaries of the mental health to follow the appropriate way of management, as well the behavioral session for those beneficiaries. We know that during COVID-19 pandemic, GBV cases and mental health cases was increased obviously during the pandemic due to lack of resources, due to funding problem, due to like social problem, and increased cases of depression and anxiety. Also, we noticed that we had increased around 30 to 40% of cases of women of moderate depression, especially in women. So we start to adapt the work on the center to mitigate this percentage and to helping them to cope with the management during COVID-19.
And thank you so much, Dr. Salman. I have another question from Eliana Irato. I would think about Krista to answer, but again, we are all free to answer and we'll be happy. Besides access to remote service provision, any finding on potential impact on the quality of service provision? I think the person referred to GBV services.
Yeah, sure. Thank you for the question. I think it's a very important one. And maybe some of the other panelists can join in. So given the timing of the desk review that happened, when the pandemic was early on, like I said, between 2020 and the spring of 21, we didn't find any evidence that really talked about the quality of of programming and the remote service provision. Certainly there were a lot of challenges, and during that time, a lot of organizations emphasized the creation of standard operating procedures to ensure the quality. So a lot of providers had initially said that they were struggling to know when to reach out to survivors in order not to exacerbate the GBV risks that they may experience, so we didn't find a lot of evidence on that, but I turn it over to the other panelists because maybe they can speak from their experience.
Yeah, definitely there was some impact on the quality issues at the time, at the beginning of the COVID situation. And you were rightly said that at the time we were facing a new challenge, and we were trying to adapt with the situation, and we were developing a lot of policies and things. But in the meantime, we have the documents in our hand, and we are now trying to accommodate our services with those SOPs and guidelines. Definitely now the services are much more qualityful from the beginning of the COVID-19 pandemic. Thank you.
Thank you, Dr. Alam, and thank you, Krista. I have another question that is directly addressed to one of the panelists, so it's easy. So it's from Beatrice Beer. I would like to know from Dr. Hur Amer to explain a bit more about the red line that determines the need of survival during COVID-19 in Iraq.
Yes. Actually, what I mentioned regarding the survivors of the GBV, it was a little bit hard through the phone call because they cannot reach the center, so we cannot determine the full needs of their requirements, their needs. We cannot do full assessment for their cases. So. Then once the curfew became less, they came to the center, and we start to determine more need. We cannot actually measure the progression of the management. I mean, remotely it is so hard because actually we know we need to document all the needs of those survivors. In the same time, and if the case came to the center and they can see the case manager, the psychologist, they can speak freely, they can discuss about everything through the phone call. They don't feel it is reliable, and some of them they don't use maybe they don't use phone call, or remotely is so hard, or if the mobile team, the outreach team can if they can visit them at home, they cannot talk freely about their needs. So once they come to the center, they feel more private and more comfortable for them to discuss their situation. So the number of the session was decreased due to limitation of access due to pandemic. I mean, so their need was. They feel not comfortable during other way. So even the follow-up process was not so reliable for them to do unless they discuss with the psychiatric, with the case manager, and they can listen and discuss freely. And once they come, they have to stack on the time that appointed by the staff. For example, if the psychiatric or case manager determine they have to come in this time, if they late, so they cannot catch the staff in another time, because there are another beneficiaries or another survivors will come to the centers, so there should be change in appointments. And this make problem for them because they have to be stuck and no delay at all.
Thank you, Dr. Salman. And there were a few other. Go ahead, sorry.
I'm sorry, I hope I answered her question.
I think you did. Thank you so much.
Yeah,
I mean, there were a few other questions, but we have come to the end of this webinar. We had 1 hour, it flew like this. And we want to thank once more our panelists, Dr. Salman, Dr. Alam, and Dr. Balami, and the presenter, Dr. Bywater and Ms. Saba Zarif, for their contribution. We also want to thank the co-host, the Global Health Cluster COVID Task Team, and the READY initiative funded by the Bureau for Humanitarian Assistance. We hope you have found this webinar interesting, and I want to thank you all for your participation and reminding you that in the coming few days, you will receive the recording of this session. Again, thank you, and thank you all for the participation, and thank you to the panelists and presenter for the great webinar. We hope we'll do more since there is a lot of interest. Thanks.
Thank you.
Thank you so much. Thanks. Bye.